dear Chairman, dear moderators, dear colleagues, thank you for allowing me to present this work. The title is Mortality Prediction Using Machine Learning, Insights from the France TAVR Registry. My name is Pavel Overture, and I would like to thank all the people who have contributed to this work. These are my disclosures. So, why do we use risk prediction scores? What do we use them every day? We use them, first of all, for research, to stratify the patients for the randomized trials. We also use them in the observational studies, as well as routine clinical practice. We, for example, use it for aortic stenosis to decide upon what would be the best strategy of treatment for a patient with aortic stenosis. Should it be TAVI or open surgical aortic valve replacement? The European Society of Cardiology guidelines of 2017 recommended the use of the STS score or the Euroscore 2 with a threshold that they put at 4%, or the Euroscore 1 with a threshold of 10%. Since the guidelines were published, several major randomized trials in low-risk patients that have compared TAVI to surgical aortic valve replacement, they have found that there is at least non-inferiority of both techniques. Then followed shortly after a meta-analysis that has actually regrouped data from all the randomized trials across all surgical risk strata, and found that there was at least non-inferiority for actually irrespective of the surgical risk strata, low risk, high risk, intermediate risk, all the same. So why do we keep using them then? If they don't help us to decide what would be the best strategy, what do we keep using them? Possibly the surgical risk scores have less predictive ability for TAVI patients. It's a hypothesis. In literature, you have a drop of area under the curve from surgical cohorts to TAVI cohorts. So people have tried to develop TAVI-specific scores. We have these two publications, the North American STS-ACC-TVT TAVI score, and also the English UK's TAVI score. Both of them have reported an area under the curve in the index populations to be between 0.65 and 0.67, which is fine, but they possibly lack external validation and also individualized risk estimation. Why? Because if, for example, if you take the TVT-TAVI score, you look at the 7 characteristics that are used for risk prediction, and you notice that 5 out of 7 actually dialysis, NYHA class 4, severe lung disease. So in France, TAVI dialysis was observed in 2% of patients. NYHA class 4 in 10%. Severe lung disease in 10%. So actually, if you account for the overlapping of these patients, you end up classifying most of your cohort on age and renal function. So it's not very individualized, actually. The classical approach will be a little bit more technical here. The classical approach that has been used in all these risk prediction construction of these models was a logistic regression model, which is actually trying to fit the patients on this logistic regression curve. You have here's a positive event, which is death, and here's a negative event, which is survival. And when you have a major dissymmetry between the two classes of the outcome event, which is mortality, yes or no, you have a model that ends up classifying all patients toward the negative event. So we have a model that tends to predict the negative event, actually. So what could we do? What we could do is to use a methodological magnifying glass to try to better discriminate the patients that are grouped here. So our hypothesis was that a machine learning approach could yield a better mortality prediction performance. We had two main objectives. One was to build a predictive model for in-hospital as well as one-year mortality after TAVI using machine learning. And the second, to compare its performance through the recommended and commonly used surgical risk scores. We used two major cohorts. One was the France TAVI registry, which is a national cohort for model development and testing. And we use also an independent validation cohort, which was the Swiss burn TAVI registry. The France TAVI database has been previously described. It included more than 12,000 patients across all France, more than 40 centers. Between 2013 and 2015, we used data pre-processing techniques, notably to account for the outcome class dissymmetry that we talked about, using what's called a smooth technique, which is short for synthetic minority oversampling technique. And the main predictive model that was trained was a shallow neural network. We had two major study endpoints. One was the area under the curve, which represents the global performance, predictive performance of the model, and the net reclassification improvement index, which represents the proportion of patients which are correctly reclassified with a new predictive model as compared to the previous one. This is a flowchart from the baseline France TAVI database, which included more than 12,000 patients. Patients were separated randomly into two databases, one training database and the second one the test database. This is a classical machine learning approach. The training database was used for model training, and the test database was used for model testing and to compare the predictive model to the surgical risk scores. Then the model was tested independently in the validation cohort, which was a Swiss burn registry. This is a graphical representation of the predictive model. We used more than 20 variables that were selected for their univariate association with the outcome event. They represented patient history, symptoms, biology, echocardiography, and some foreseeable procedural characteristics. These are some of the first results on these probability density plots. You can appreciate that the neural network model that was built has a much larger spectrum of probability estimations, which is different from the surgical risk scores, for which you can see that their probability is actually skewed towards a negative event. It was observed for in-hospital as well as one-year mortality. On these receiver operating curves, you can appreciate that the area under the curve for in-hospital mortality was significantly higher for the neural network model that was built and trained. It was also observed for one-year mortality as well. Some numerical values for in-hospital mortality. The neural network model yielded an area under the curve 0.65, and for one-year mortality, an area under the curve of 0.63. It was significantly higher than any of the surgical risk scores. The net reclassification index was statistically significantly superior to 0. You have values when the neural network model was compared to Euroscore 1 of 0.27, when compared to Euroscore 2 of 0.17, and when compared to the STS score of 0.21. The tested threshold here to separate low-risk versus high-risk patients was 4%. We then tested the predictive model that was trained on the France TAVI database on an independent database, the burn data. And the model was found to have a predictive performance that was stable with an area under the curve of 0.68 for in-hospital mortality and 0.65 for one-year mortality. Overall, the machine learning approach allowed us to build a predictive model that had a better global predictive performance as attested by a significantly higher area under the curve. It allowed us to build a model that had a better discrimination of low versus high-risk patients, notably by better screening for the high-risk patients, which is clinically relevant since it would allow clinicians to deploy preventive measures. Despite the model being performant and stable across databases, the area under the curve remained below 0.7, which could probably be improved. We possibly lacked, this might be due to the lack of data included in the TransTAVR database, notably regarding frailty, profiling, biology, extensive imaging data, environmental data. All of those could be associated with all-cause mortality. The model that was trained and built has been made open source on the internet. You have here the address with an example of a female patient of a 65-year-old, NYHA1, not much comorbidities except coronary artery bypass grafting, left ventricular ejection fraction of 60% treated with an iliofemoral pathway. Her mortality probability has been estimated to be 0.2%, and she was classified as a low risk. Another example, here we have a male patient, a 90-year-old, who has a NYHA dyspnea class 3, critical state, previous episodes of heart failure, treated through the iliofemoral pathway with a left ventricular ejection fraction of 30%. This patient has been estimated to have a probability of mortality in hospital of 26% and classified as a high risk. So this is for now the predictive model that turns on a cloud, and we are currently building the server to have an independent server. So the URL, the address might change during this month, but the probability estimator is functional. So please try it and tell me what you think. Thank you.
Thank you very much.
Very nice presentation indeed, but I would like to know the practical, let's say, importance around this findings. Do you mean that sooner or later, using these algorithms, we could modify our practice about the patient selected for operation, or even the insurance companies could be relatively reluctant to cover high-risk patients according to your algorithmic approach?
So it's a good question. We had this problem probably already with the surgical risk score. Some of them classified patients as to be high risk, low risk, intermediate risk, and well, we could ask ourselves what would be the impact on the insurance companies and all that. For the insurance companies, I would say, well, the model is good, it's performant, but it's not 100%, so you shouldn't use it. For the clinical use, it's still pertinent because patients that will be classified as high risk, you could deploy some preventive measures, meaning, for example, if you have a patient that's in stable critical state with an urgent procedure, possibly you could have a better strategy, stabilizing him first. And if you have for example, a patient with that will have major comorbidities or coronary stenosis, possibly you would want to first treat the coronary stenosis in order to reduce the intra-hospital risk.
Okay, thank you very much. Do you think you compared your risk score to established surgical risk scores, right? But as you showed us in the introduction, there are several newer sort of TAVR risk scores. Did you compare your risk score with those newer scores as well?
It's an excellent question, and we are working on it. And we're confident that it works.
Okay, thank you very much. Thank you.
Thank you.
Okay, great.